Now live. So welcome to this morning's discussion on the Seinfeld episode, The Baby Shower. All right, so group, where would you like to start?
I thought it was kind of funny how the whole episode George is talking about, like, saying what he wants to say to this girl who took him to the play and then, like, dumped chocolate on him, and he's hyping himself up the whole episode, and then when he finally gets the chance to do it, another girl, like, kind of lived out his dream in front of him to Jerry, and then he didn't take it as an impetus to like say what he wanted to say to the girl.
Mm-hmm. Let's carry this through. I think there's several points to make here, both applicable to the shelf exam and maybe clinical pearls as well. Number one is this: the observation that George thinks, if not overthinks, a particular scenario, but when the time comes, is unable to carry through with everything that he's planned, everything that was his executive function. And that's irrespective of the other characters actually stepping forward and saying what in fact she was thinking or perhaps even planning. First and foremost, and you hear me say this more than once, I'll remind you every week, when we see behavior like this, the first thing I want you to think of as a psychiatrist or as a future psychiatrist is that is completely normal. Right? And I want you to take that into your clinical practice, and it doesn't matter if you're sitting in a family practice clinic, psychiatry clinic, or other. Irrespective of your patient's chief complaint, from a behavioral perspective, it's always normal until it's not. And if a person's coming in with a chief complaint that is consistent with a mental disorder, and you feel that every time that happens, literally 99.9% of the time, it is always abnormal, continue to allow your brain to give your patient unconditional positive regard until the information is presented to you. It's going to be frustrating. And you're going to look back on today, you're going to look back on your psych rotation and think that Dr. Toby's a quack. It's a waste of my time, but it's a great way to address patient care. All right. So along those lines, what we're seeing here from George is completely normal. However, there's more to this particular subplot. There's more to this character. What is it that you've observed that perhaps will move you off that starting point so that we can begin talking about mental health and mental illness?
About George?
Yeah.
Seems like a classic overthinker.
Are you drawing your conclusion from this episode, or have you watched Seinfeld before?
I've seen a bunch.
All right, so that's called a past psychiatric history, if not a developmental history. It is. I mean, we do the same thing in clinical practice. There's a parallel here. And for those who've never watched Seinfeld before, welcome to medicine, where you may not know everything you want to know about your patient, or little to nothing about your patient, but you're going to be consulted on them to provide your clinical expertise nonetheless. So it works both ways. He does tend to overthink things. He does have intrusive and obsessive thoughts. My question here is if there's 9 seasons here we have to work with. So again, 9-year history. But that said, do we feel that this is recurrent? And you already gave me that answer, which means that we're probably going to move off that starting point of saying that's completely normal. And maybe it is, in fact, abnormal. Once we establish that, and that is true, what then differentiates abnormal behavior that we observe that is outside a culturally sanctioned norm, and that which is disordered? When do we get to call it or label it a mental disorder?
It's impacting functioning during daily life.
Exactly right. And that's per the American Psychiatric Association. And the next question then is for George Costanza, or as of information presented to you in The Baby Shower, does it appear to cause clinically significant distress or impairment in George's functioning?
I would say yes.
Yeah. Right.
Because he specifically wore the shirt that he wore the play, and then he picked up Jerry at the airport, even though he wasn't invited to the baby shower at all, and Jerry could have driven or gotten a cab home, and George was persistent that he wanted to do it. He wanted to pick Jerry up and all this, and even Jerry points out that he's out of his way to do so.
And I think it's also fair, and again, if we were therapists, if we were a psychiatrist sitting during the initial evaluation, one of the things that would pop up that we would strongly consider asking is whether or not these recurrent behaviors, these repetitive behaviors, have resulted in clinical impact. And cheating, looking at those 9 prior seasons, and I don't really know where the baby shower sits in terms of season and episode, but we do have 9 years to work with. It does impair his social and interpersonal functioning. And it also, this behavior, we also know that George goes a significant number of episodes without jobs either. So yes, the answer is going to be yes here. Right? Only now can we begin to develop a differential diagnosis. Right. So the way we teach you psychiatry, the way we teach you every clinical aspect of clinical medicine is you think about something, you highlight what jumps off the page at you, usually on a shelf exam, and you choose A, B, C, or D, and you're off, 30 seconds or less? In the real world, we have to think through things a lot more. You have to actually unlearn the way we've taught you to think about medicine. And it's aspects like this that again, reemphasize that there's plenty to talk about before we even began talking about our differential. Like, we don't even know what answers A, B, C, or D are yet, but only have arrived that this is a mental disorder nonetheless, right? So at this point in the discussion, if we were to choose a place to start, what do you think is going on in the baby shower pertaining to George Costanza when it comes to mental disorder, and why?
Some sort of like delusional disorder, like he's having these delusions that she purposely spilled the chocolate milk on him, and that he thinks that she's out to get him, and so maybe some sort of like delusional, like major delusional disorder. So
you're going to put words in your mouth now. You're telling me that you observed a deficit in thought content. Thought content being one of the domains of the routine mental status exam, right?
I want to say yes, but I'm unsure.
No, you're right.
Okay.
Yes. All right. So there's an observed deficit in thought content. What other, excluding suicidal ideation and homicidal ideation, what are the other deficits in thought content beyond a delusion? This is anybody. I know I keep on looking at one student. This is for the group, by the way. And everybody's looking down at their computers, not to make eye contact, but...
Like linear thinking, logical thinking.
That's more process than content, but that's true, yeah. So, and it all come under the T in the acronym ABC stamp liquor, which I did not make up. Right? It's brain calipers, so full reference there. But, so that's the T. It's thought. Thought can be thought process versus thought content. Deficits in thought content other than SI, HI, or delusion.
Hallucination.
That's more perception. That's the P in ABC stamp liquor. Obsessions. Other terms you might hear are ruminations, preoccupations, right? So, and unfortunately, if you ask 100 of us, 100 psychiatrists, differentiate the rumination from the preoccupation, from the obsession, from the delusion, you're going to get 101 different answers. So let's review these, all right? There is a term that I have not yet mentioned that is considered to be different than all of the above, perhaps the mildest form of deficit. Mildest, operationalized by, in fact, not impacting functioning, right? So that's called the overvalued idea, right? So it's mid to late October, I wish, mid to late August. I think we have our fantasy teams done already. If not, your draft is probably coming up. And we are literally weeks, if not days away from some of us in this room dressing up in a particular color, sitting on a particular area of our living room, and not moving or not taking that colored jersey off until your team scores or wins, right? Otherwise, bad things are going to happen, right? Now, are you delusional? No. With all due respect to your roommates, perhaps significant others, partners, this is not clinically impactful. It is not causing clinically significant distress. It is not. Or impairment in your functioning. So by definition, it's an overvalued idea. It's subculturally sanctioned. That subculture being fandom. Right? And if you're not a fan, if you're not a fanatic of, in this case, a football team, you probably don't know what I'm talking about. Right? Or if you do know what I'm talking about, you're thinking, there's clinical significance and he's wrong. But we're going to let that go. All right? Everybody get that? Overvalued idea. I mean, outside of this room, outside of clinical medicine, maybe we'll refer to it as a superstition, but overvalued idea sounds more professional. When the overvalued idea does result in clinically significant distress or impairment in functioning, we have to change the name, right? We can't call it an overvalued idea anymore. And there we can say preoccupation versus obsession versus rumination. I think for your level of training, for all intents and purposes, those are interchangeable. Those are intermediate forms, or in terms of severity, of thought content deficits, right? They are clinically impactful, so they are more severe than that overvalued idea. However, they do not reach that clinical threshold of labeling it a delusion. Delusions not only are a breach in reality testing, and obsessions and preoccupations are as well, but delusions differentiate from the rest in that they're fixed. That despite being presented information to contradict the person's thought, those thoughts remain fixed. Insight is the rule when it comes to the obsession, preoccupation, rumination, and that the individual, and this may not be always straightforward because there are times in which this will wax and wane definitely, but at some point there's going to be some demonstration of insight that what they are thinking isn't right, but they can't shake the thought anyway. With all of that as a ultra brief primer on deficits in thought content, reviewing that aspect or domain of the mental status exam, do we think George Costanza in this episode is delusional, or do we think he's struggling with a lighter form of thought content deficit? And might we otherwise label that form an obsession? I'm getting now which one?
I don't think he's delusional.
Okay. So he escapes the diagnosis of delusional disorder, perhaps, or maybe a psychotic disorder in general, and instead looks like he's struggling with an obsession. The unfortunate nature of this, and we have to contact Larry David, maybe he can rewrite the script, but I don't see any aspect of compulsive acts or compulsive behaviors. So that then rules out OCD, doesn't it? That's a trick question, it doesn't. What number of people and I think I have to state the obvious first, the American Psychiatric Association, the DSM-5, allows for the diagnosis of OCD with obsessions only, with compulsions only. You don't need both. Matter of fact, up to blank percent have obsessions only. Fill in the blank. What's your guess? 10 to 20. And maybe George Costanza's in that 20%, or within that 20%. And this might be obsessive compulsive disorder. Questions about OCD, George's obsessions, or any other aspect of this character in this subplot discussing the baby shower?
I was wondering, for him, it definitely sounds like more OCD than OCPD, but then the egocentric is not, is kind of...
Yep. So let's get into that a little bit, because I think while your board review texts are not incorrect, they're misguided. When we begin to discuss the differential diagnosis, in this case, it would be what we're talking about, obsessive compulsive disorder versus obsessive compulsive personality disorder, or OCPD. There are other aspects of each that readily differentiate even before we get to ego dystonic versus syntonic. Right? So I understand where the board review texts are coming from, but saying that ego syntonic versus dystonic readily differentiates is like saying the difference between an ant and the Empire State Building is that one is gray, the other one is usually black. Also true, but there might be more to it that is more readily identifiable, especially in clinical practice. So let's talk about OCD. If you ever hesitate as to identifying this, perhaps on a shelf exam, just remind yourself, you literally can look at the label, the diagnostic label, and the DSM criteria are contained in there. Individuals with obsessive compulsive disorder have obsessions and or compulsions, and their behavior is disordered, meaning that it results in clinically significant distress or impairment in functioning. That's it. Any questions about OCD? When you look at OCPD and you hesitate, wondering if choice blank is the single best answer, remind yourself that if you look at the diagnostic label, none of the diagnostic criteria are there. Now there's one small exception. That is, OCPD, and nowhere in its definition and nowhere in its clinical criteria will you see the word obsession. Nowhere will you see the word compulsion. The only thing that you will identify is that it is also disordered, in that the personality disorder is a disorder, in that it does result in clinically significant distress or impairment in functioning. It's the only thing it shares with its namesake, OCD. If that is the case, and if the personality disorder has nothing to do with obsessive thoughts or compulsive behaviors, then what is it? What does it look like? How will somebody sitting across from you, making an appointment for management of their OCPD, present? What will they tell you what's going on? And the hint is, they're not going to tell you about any intrusive thoughts or obsessions. And they're not going to tell you about any compulsive behaviors. If they do, there's something co-occurring. And these two are comorbid, often. That said, they're separate. OCPD, how does it present? Like a type A personality. They're perfectionistic. They're micromanagers. They need control. They need order. Type A personality. If you look at the diagnostic criteria, everything that is listed there reads type A. Now, we're not going to, I think our discussion this morning is such that to go further into this would be a little bit beyond the scope of Seifeld. But the reason why these two seemingly different, at least by definition, conditions have a similar name has everything to do with etiology, right? And that's the defense mechanisms. And for now, I'll just mention that the defense mechanism that is thought to cause both the anxiety disorder, OCD, and the personality disorder, OCPD, is isolation of affect. So because of the common etiology, they have common sounding names. Just think of it like that. But the two, they present very, very differently. Yes, one is egosyntonic, one is egodystonic, but boy, you're missing the bigger picture if that's all you're going with. Questions about OCPD, OCD, or anything else pertaining to George Costanza? What other characters caught your eye in the baby shower?
Like Elaine, when she's like planning this baby shower for Leslie and they're out to eat and she's like, well, I don't really even like her, but I'm like doing it anyway because like I feel like I want her to like me. And then even during the baby shower, she is like talking about the Kennedys, even though she said like, oh, I don't care about them, like why is everyone so obsessed with them? And she's like very worried about what Leslie's thinking of her.
Thoughts? One, non-clinical observation, Elaine and George are more alike than they are dissimilar. Right? Both have that need. And if that need is clinically significant, if that need does result in clinically significant impairment or clinical distress, it may be a disorder. Right? Where does this come from? Whether it's George, whether it's Elaine, if either character was sitting here, what might be some questions? It probably won't be the initial assessment, but certainly follow-up, especially if the follow-up is going to include psychotherapy. What are some questions on your mind that you think you'll wind up asking them? Who knows? Session 1, session 21. What is it that we're seeing demonstrated here? It's called an external locus of control. That somebody's self-worth, their self-image, is externally infused and isn't something that they find internalized. Right?
So like insecurity?
Yeah. Mm-hmm. Yep. And when in doubt, always go back to early childhood experiences. Go back, when we see disrupted relationships, always go back to the primal relationship, and that's usually child and parents. That can be modeled, or that can be something that they experience as a child, mom, dad, other. Okay? Again, a little bit beyond the scope of what we're going to discuss this morning. In ending, we have about 5 minutes left. I do want to just mention Leslie, since you did name this character. It is a baby shower. She gives us information that she is scheduled for a C-section. Why?
She said if she goes through real birth, her therapist said she becomes psychotic.
Yeah. I think Larry David inserts that for comedic purposes. However, there's some clinical relevance to that.
Postpartum blues? Or
Yeah.
Postpartum depression?
Yeah.
Oh, yeah. Postpartum psychosis.
Yeah. Yeah. So let's say Leslie is referred by her therapist to you and tells you the same thing. Now, what questions do you have for her? This is her first baby, right? Yeah. So I think the obvious questions are now off the table, right? Which is past history.
Any psychiatric history?
Yeah. Yeah. So what specifically?
Like depression?
Yep. She tells you that she has no prior episodes of depression.
Any episodes of like psychosis or hallucination?
So she tells you that no, not psychosis.
What does that mean?
What does psychosis mean?
What do you mean by not, like, when she says no, not psychosis? What does that mean to her?
What it means is that the etiology of postpartum psychosis is thought to be an gene expression of latent or occult bipolar disorder. That's what it means. Right. Good pickup on my inflection. That's called nonverbal behavior. That said, it's a minor character, sure, and I don't think she's even mentioned in any other episodes. But she does allow us to teach not only postpartum psychosis, but differentiate it from the postpartum blues and peripartum depression. And I'll actually post a slide differentiating those three conditions on Instagram later today. That said, emerging research does suggest that the trauma of childbirth, and this is the physiologic trauma, although emotional trauma certainly plays a role here too, likely results in gene expression that itself results in the behavior of postpartum psychosis and ultimately bipolar I illness. So something to consider here. So I'd want to know from her not only if there's past psychosis, but past signs or symptoms suggestive of mania, that's dig fast. And then in addition to that, whether or not there's any family history of bipolar. Bipolar I, especially in first-degree relatives. Yeah. So we'll end there. Again, very minor character, but certainly allows us at least an introduction to the mood disorders in general and the bipolar and related disorders in particular. Right? We'll pick this up somehow, some way this afternoon at noon when we meet. I'll have you guys figure that out over the next 3 or 4 hours and exactly how that might transpire. But until then, we'll check out. We'll begin morning rounds and be back at noon.